So my name is Dr Chee Kay Cheung. I'm a consultant nephrologist and honorary associate professor at the University of Leicester, and I am a specialist in glomerular diseases, especially in IgA nephropathy. Today I'll be providing an expert perspective on the role of B cells in the pathogenesis of IgA nephropathy. So IgA nephropathy is a chronic and progressive disease that carries a high lifetime risk of developing kidney failure, which has a significant impact on patients. Patients are often diagnosed young, so it carries a high socio-economic burden, and it's vital to treat this disease early to protect as much kidney function as possible. Current treatment options are limited, and so new therapies are urgently needed to try to slow or halt the progression of this disease. Some people will have episodes of visible blood in the urine or visible hematuria that coincides with an upper respiratory tract or gastrointestinal infection. But in many, the disease can be silent with no signs or symptoms. So it's often detected incidentally, for example, if a patient attends their physician and the urine is tested and there's a finding of blood or protein on a dipstick. And so the diagnosis is often picked up late. We know that recent observational studies from large registries have shown that unless the rate of kidney function decline can be slowed significantly, almost all patients with IgA nephropathy are at risk of kidney failure within their lifetime, which clearly has severe and long-lasting implications. We estimate that up to half of all patients with IgA nephropathy will progress to kidney failure. It's vital to understand that kidney function has to last a lifetime, and efforts really need to be made to diagnose the disease early and to institute treatment early in order to slow or halt the progression of kidney disease and protect as much kidney function as possible. IgA nephropathy is a disease of the kidneys, but it starts outside of the kidneys in blood. It starts because B cells, which are antibody-producing cells, produce a specific form of IgA called galactose-deficient IgA1. And this lacks galactose residues from the hinge region, and this form of IgA is mainly produced at mucosal surfaces by B cells. Galactose deficient IgA then enters into the circulation in patients with IgA nephropathy, causing autoantibody production, immune complex formation that then deposits within the kidneys and leads to kidney damage. So critical to the role of converting naive B cells to IgA producing cells are the B cell survival factors, BAFF and APRIL, that are within the blood that are responsible for the survival of B cells and promoting the formation of galactose deficient IgA that we see in IgA nephropathy. We know that both BAFF and APRIL are really critical for B cell survival, proliferation, maturation, and the class switching of naive B cells to IgA producing cells. And the two cytokines work synergistically in promoting plasma cell survival, and plasma cells are the key source of antibodies in IgA nephropathy. There's evidence from observational studies that levels of BAFF are increased in patients with IgA nephropathy. We've also seen in preclinical mouse models that overexpression of BAFF leads to an IgA nephropathy-like disease.